So this is the session 4, or our last session for today, and I want to remind everybody that we have really excellent plans for tomorrow morning as well, so I hope everyone can continue to join us. We're going to continue with disease-induced deficiency in conditionally essential nutrients and disease for our last session. And I just wanted to follow up on my colleague Alex's comment about some sports, and that having gone to high school in Villanova, people probably know where my allegiances lie. However, the fact that I'm a little old lady makes me really sort of sad about that team up in Chicago that came so close to really making a big wave for themselves. And he didn't ask how many in the audience were for Loyola. So just want to see a show of hands. Who would have liked to have seen them continue? Yeah. Okay, so our first talk is on arginine as an example of a conditionally essential nutrient in sickle cell anemia and surgery. Claudia from Emory University.
Thank you very much, and I'm delighted to be here. As a pediatric emergency medicine physician, I don't always have the opportunity to discuss nutrition with my colleagues, so this is wonderful to be surrounded by like-minded people. So just to start off with some of the questions we were tasked with, when does a physiologic state result in a unique nutritional requirement? Well, as I think most in this room understand, that essential amino acids are diet dependent, whereas non-essential amino acids are not required in the diet because your body's able to make it through de novo synthesis. But then there's this basket of conditionally essential amino acids. So they're non-essential amino acids that ultimately become indispensable under stress and critical illness, where the capacity of endogenous synthesis is surpassed. And arginine is one such amino acid. And there's actually a number of conditions that are associated with acquired arginine deficiencies, and we're going to focus on sickle cell disease and the process of hemolysis that leads to that, trauma and surgery, and there are going to be other talks following mine on surgery. But there are other conditions as well, and in particular, to point out pregnancy, where actually this arginine deficiency may be protective by maybe dampening our immune system so that the mother doesn't overreact to the infant. So what exactly is arginine? Well, it's a conditionally essential amino acid that's found in dietary protein. It's synthesized through the intestinal renal axis, so something to make the GI doctors and the nephrologists happy here, and ultimately becomes essential under conditions of stress. Now, it's found naturally in diet, and people ask, well, what foods are high in arginine? High protein foods, so meat, dairy, seafood, nuts, even watermelon. But it turns out that studies that have looked at cardiovascular disease to increase nitric oxide metabolites usually require 7 to 10 grams of arginine 2 to 3 times a day, so that really can't be met by diet. And it's a nutritional supplement with low toxicity, and ultimately it's the obligate substrate for nitric oxide production, which is a very potent vasodilator that's important in regulating your blood pressure and has a number of other important physiologic effects. So arginine, that looks a little funny. Arginine gets converted to nitric oxide through the actions of the enzyme nitric oxide synthase. And as I mentioned, it regulates vasodilatory tone, but also has an effect on platelet aggregation, immune response. It's a signaling molecule and can have some antioxidant effects. It's also the substrate for arginase, which is an enzyme, an important enzyme in the urea cycle. But there's 2 mammalian isoforms, arginase 1, which is cytosolic, and arginase 2, which is mitochondrial. And arginase is actually present in most cell types, including the red blood cell, which makes it a really intriguing enzyme to study in hemolytic disorders where it gets dumped into circulation in an active form where it doesn't belong. And then we're going to touch base on myeloid-derived suppressor cells that has an impact in trauma. Arginase is also upregulated in inflammation. We heard a lot about that in the last session, induced by cytokines, and ultimately competes with nitric oxide synthase for its common substrate of arginine. So in the presence of arginase, arginine gets converted to ornithine and urea. Ornithine and arginine use the same amino acid transporter, CAT1 and CAT2, so when your ornithine levels go up, you're basically inhibiting your cellular uptake of arginine depending on how high your ornithine levels are. So this could ultimately translate to decreased arginine bioavailability and decreased nitric oxide bioavailability. So you can't just look at plasma arginase and figure out your arginine bioavailability, because there's a lot of other factors that come into play, like the presence of these other amino acids that compete for intercellular transport. So this slide just is a nice summary of the arginine metabolome. As I mentioned, arginine gets converted to nitric oxide by nitric oxide synthase. In many conditions of inflammation, NOS is upregulated, yet you have this paradoxical decrease in nitric oxide production. We know from the sickle cell mouse model and other models of inflammation that nitric oxide synthase, although it's upregulated, is really not functioning properly. And it can become uncoupled where it produces superoxide in lieu of nitric oxide. So now you've got a dysfunctional arginine to nitric oxide pathway. Then you have substrate competition from arginase, which can come from a variety of sources, that converts arginine to ornithine and pushes down this proliferative pathway, prolines, polyamines. This is a pathway towards vascular smooth muscle proliferation, airway remodeling, lung fibrosis. So if I think about the lungs, where I'm going to be talking about or focusing on sickle cell disease, these are the sort of changes, structural changes you see in the lungs with patients who develop pulmonary hypertension, which is a comorbidity that's very commonly seen in patients with sickle cell disease. So now arginine should never be rate limiting in health because, as we mentioned, it's a conditionally essential amino acid. Your body has the ability to make it through the intestinal renal axis. So it's taken up in the form of glutamine, converted to citrulline in the small intestine, converted from citrulline to arginine in the kidney. So you can see that if you've got gastrointestinal problems, this can actually affect your ability to synthesize arginine, or if you have renal dysfunction. So it's important to think about the whole body. What's interesting is that glutamine actually just got FDA approval for the treatment of sickle cell disease, decreasing pain and acute chest syndrome. And actually, glutamine is an arginine prodrug. And I call it a prodrug because now glutamine is considered a drug by the FDA. It has a fancy name and a very fancy price tag, but we still know it's just a nutritional supplement. So when we think about arginine bioavailability, we coined the term global arginine bioavailability ratio, and that's reflected by arginine over the ratio of ornithine plus citrulline, and that actually takes into account so much more than just the plasma arginine. It takes into account your impact of arginase, your impact on elevated ornithine levels and intracellular transport, and then it also takes into account the effects of renal dysfunction. And it turns out that this biomarker actually correlates to important clinical outcomes. So I think we all know that a drop in any single amino acid does not translate to a clinically significant deficiency. In order for a nutritional deficiency to be present, you have to have a biological process that's dependent on that nutrient that's compromised. That compromise needs to lead to abnormal physiologic response that's causative of poor outcomes, and those poor outcomes need to be reversed by amino acid replacement. And it turns out that sickle cell disease is a beautiful model for distinct nutritional requirements that arise from a chronic disease. So as I go forward, we're going to talk about the biologically plausible process that's dependent on the nutrient is endothelial function. The compromise, we're going to pick pulmonary hypertension. We're going to talk about that in a minute, which is associated with increased mortality, so poor outcome. And then we have some data to show that we're able to reverse pulmonary hypertension with arginine supplementation. And then I'm not going to go too much into the trauma piece, but trauma is an interesting model for distinct nutritional requirements for an acute illness. So before the trauma, you didn't have an arginine deficiency, but it develops acutely. So for the non-hematologists in the room, sickle cell disease is an inherited disease of the red blood cells. It's autosomal recessive and ultimately affects hemoglobin, where you have hemoglobin polymerization that leads to a cascade of events that eventually decreases your blood flow. And basically it causes tissue hypoxemia, causes acute and chronic end organ damage in every organ system of these patients from head to toe. And you can see as the hemoglobin polymerizes, it turns this characteristic sickle shape that ultimately blocks the vasculature and causes a great deal of pain. It's a terrible disease. 8% of African Americans carry the sickle trait, and 1 out of 400 African Americans in the United States, or approximately 100,000 individuals, have sickle cell disease in the United States. So it is an orphan disease, affecting less than 200,000 individuals. But it affects millions of individuals worldwide and sort of follows the malaria belt, because sickle trait is protective against malaria, but sickle cell disease is a terrible disease. Over 75,000 admissions a year with a cost of over $470 million, so significant financial burden as well. So, and because these sickle cells sickle, they're at increased vulnerability to hemolysis, which is the important mechanism that's going to lead to this arginine deficiency. So sickle cell disease is a beautiful model of vasculopathy. I'll show you how hemolysis and inflammation plays a role, but also ultimately it translates to nitric oxide and arginine depletion. So there's a number of mechanisms of vasculopathy in sickle cell disease, with the depletion of nitric oxide taking central stage. So normally safely encapsulated within the red blood cell is all the contents of the red blood cell, which break apart and get dumped into circulation. So now you have your hemoglobin, which is now free, rapidly consumes nitric oxide, so depletes your nitric oxide. Also within the red cell is arginase, which will rapidly consume the obligate substrate for nitric oxide production. So now you've got decreased production, increased consumption. As your arginine level drops, you reach a threshold level below which nitric oxide synthase uncouples and produces superoxide in lieu of nitric oxide, further consuming nitric oxide and adding to this milieu of oxidative stress. So it seems that you have this global disruption of the arginine nitric oxide pathway in sickle cell disease. And this isn't just sickle cell disease, though. This is a process of hemolysis. So it's important in thalassemia, malaria, even blood storage lesion, wherever the red blood cell is breaking apart. So what's interesting is also within the red blood cell is lactate dehydrogenase, LDH, which we think is of no clinical consequence, but it makes a beautiful biomarker of the hemolytic subphenotype of sickle cell disease. And that's because there are consequences of decreased nitric oxide bioavailability. We talked about the vasoconstriction, inflammation, increased endothelin-1 and platelet activation, but there's also clinical manifestations, so increased risk of stroke, renal insufficiency, priapism, leg ulcers, asthma, and here I'm going to focus again on this pulmonary hypertension. So this has been termed the clinical subphenotype of hemolysis in sickle cell disease, but it's also the clinical subphenotype of arginine deficiency. So what we found is that there's an arginine insufficiency and elevated arginase activity in our patients with sickle cell disease. So here we have a large cohort of patients with sickle cell disease. Their arginine levels are very low compared to normal controls. And this was interesting because this is the first time this was shown in plasma. You have very high arginase activity in the plasma compared to values that are barely measurable in normal controls. So as I mentioned earlier, arginase is an intracellular enzyme that's released upon cell damage and cell death. It just doesn't belong in the plasma, yet there it is. So when we talked about arginase converting arginine to ornithine, this ratio actually is a nice biomarker of arginase activity. And sure enough, it was low in our patients with sickle cell disease compared to normal controls. But what was most intriguing is that the lowest values were found at the patients who were at highest risk of developing pulmonary hypertension. So this first observation is what led me to look a little more closely at pulmonary hypertension. So that it's missing a couple of bars here. So I don't know what happened to that figure, but basically this was, this was our, well, if it's low, let's give it back. We had this data to suggest that low arginine bioavailability was associated with pulmonary hypertension severity. This study was done before we were screening for pulmonary hypertension and sickle cell disease, so these patients were symptomatic. And let's see here. You can see that some of these values, so this is pulmonary systolic pressure estimated by Doppler echocardiography, and some of these values were incredibly high. And after 5 days of oral supplementation, we were really surprised to see a significant reduction in estimated pulmonary systolic pressures by 15%. And that's actually similar to the kind of changes you see with pulmonary hypertension medications after weeks of therapy. What else was interesting is that if patients took their medication, we saw that plasma arginine levels doubled or tripled within the 5 days. Let's see this one patient here who showed no improvement at all. What was intriguing is his post-therapy arginine level was lower than his pre-therapy, and he admitted to be non-compliant. The other anecdote of this group was that 2 patients who had chronic leg ulcers, which is another comorbidity that's common in patients with sickle cell disease, years and years of therapy, their leg ulcers actually started improving on arginine therapy. So it was just, again, intriguing. And since then, there's been a phase 2 randomized controlled trial of arginine for leg ulcers that shows that arginine, that was arginine butyrate actually helped recover leg ulcers compared to placebo. So the next question, I gotta go then. The next question is, was this just a sickle cell thing, or did this have something to do with hemolysis? So we actually walked over to our thalassemia clinic and looked at a bunch of patients with thalassemia, which is also a hemolytic anemia that's associated with higher prevalence of pulmonary hypertension. And what we found is a similar pattern of arginine dysregulation. So high arginase activity, low Arg to ORN ratio, elevated downstream byproducts, which was interesting, but at the time, we didn't divide patients between those with and without pulmonary hypertension. So as I learned more about this complication, we went back to the thalassemia clinic and we looked at patients with normal Doppler echo, TR jet less than 2.5 versus those who are at high risk for pulmonary hypertension. And it turns out that arginine dysregulation was found only in the group of patients who are at risk for pulmonary hypertension. So these are all thal patients, significantly different arginine metabolism or metabolites. So you have low arginine here, low Arg to ORN ratio, very high arginase in this group, and then a low global arginine bioavailability ratio. And it turns out that this ratio correlated to biomarkers of cardiovascular dysfunction on cardiac MRI. And if you look at the patients who didn't have pulmonary hypertension, they actually had pretty normal arginine levels. So probably the next surprising observation, though, was that low arginine bioavailability was associated with worse survival. So, and this is reflected by the Arg to ORN ratio, but also the global arginine bioavailability ratio. And here you see there were no deaths, and this is sickle cell disease where you have high mortality. There's no deaths in the patients who had the highest arginine bioavailability following them over nearly 5 years, and the highest number of deaths in the patients who had the lowest global arginine bioavailability with the risk ratio of 3.6. So Stan Hazen, who's a cardiologist who was actually a collaborator on that study, had a large clinic at Cleveland Clinic and looked at a cohort of patients who are at risk for cardiovascular disease who are undergoing right heart cardiac cath. And what he found, so he looked at nearly 1,000 patients, so he found that the reduced global arginine bioavailability ratio was associated with increased risk of major adverse cardiovascular events, so defined as mortality, heart attack, and stroke. So in the yellow line is the patients with the lowest arginine bioavailability. They've got the highest adverse events. In the blue line is the group with the highest arginine bioavailability. So, and he found that this biomarker was a more robust biomarker of cardiovascular disease than cholesterol. And so what this tells me is that arginine bioavailability is a biomarker of vasculopathy that actually does go beyond sickle cell disease. So, how does a disease state impact nutrient metabolism and nutritional status? Well, I think we talked about a lot of these different mechanisms that can compromise your arginine bioavailability. It seems in sickle cell disease you have all of these, from hemolysis to renal dysfunction to uncoupled nitric oxide synthase. So when we talk about arginine deficiency syndromes, it turns out that whether it's hepatic, immune, from hemolyzed red cells during hemolysis or transfusion, or clinical consequences of excess extracellular arginase, they're similar regardless of the cellular origin. And there are really two baskets. There's endothelial dysfunction, which we talked quite a bit about in sickle cell disease, but then there's also T cell dysfunction, which we see in trauma. So it turns out that T cell dysfunction is linked to acute nutritional deficiencies in trauma patients. So now I get to wear my emergency medicine hat again. We see a lot of trauma. So how delighted was I to see that it had any kind of nutritional intervention. So arginine is essential for naive T cell activation. And it turns out that T cells are very sensitive to arginine depletion. The T cell proliferation is blunted, interferon gamma, IL-2 production is inhibited, and T lymphocyte mediated cytotoxicity memory response is nearly completely abolished when arginine is depleted. So again, if you think about pregnancy, this may have some benefits, but certainly in acute trauma, it's going to increase your risk of infection. So, and basically provision of arginine to the culture media restores your T cell function. So it turns out there's over 15 million injuries a year in the United States, and about 10% of trauma patients develop wound infections. Infection risk increases by 30% in patients who are in the ICU for over 48 hours. And infections are the leading cause of late organ failure and result in about 10% of trauma deaths. It turns out, and this is work that was pioneered by Juan Ochoa when he was the trauma chief at University of Pittsburgh's Medical Center. And he found that low plasma arginine levels developed acutely in patients with trauma. It occurred within minutes to hours, and it was prolonged. It lasted for as long as a week or more. Sorry. And he found that this was associated with increased plasma arginase activity. And ultimately, he showed that myeloid-derived suppressor cells expressed arginase 1 after trauma. So where it was the red blood cell in sickle cell disease, it's these myeloid-derived suppressor cells in trauma. Ultimately depletes your arginine, leads to T-cell dysfunction, and increases your susceptibility to infection after an injury. So strategies that are aimed at infection prevention after trauma should result in significant decrease in mortality, morbidity, and cost. So there's been a great deal of work that's been done in sickle cell disease in the sickle cell mouse model, but also in human studies. We talked about pulmonary hypertension. Anecdotally, I'll use IV arginine in the emergency department if a patient comes in with priapism because it seems to reverse it, at least in most patients that I've tried it. And there have been 2 positive human phase 2 studies, the one that I mentioned on leg ulcers, and then we completed a phase 2 trial in pain, and we're currently working on our second phase 2 trial and planning a phase 3 trial through the Pediatric Emergency Care Applied Research Network, thanks to the FDA's Orphan Drug Program. In trauma, there's actually been enhanced wound healing after trauma and hemorrhagic shock and arginine-fortified formulas. And immune nutrition improves immune response to T-cell dysfunction. High arginine formulas decrease infection complications in critically ill patients. And the benefits have been seen to be greatest in the surgical patients. But there is also evidence of harm in sepsis and following acute MI, so we have to be careful with the subgroups that we choose. And as far as trauma is concerned, methodologic weaknesses in most studies have been found, and there's really a paucity of data in children. And I know I need to tie up real quick. I just want to point one thing out, that the more I looked at in trauma and nutrition, I was horrified to find that we're starving our sickest patients in the pediatric ICU. And so as I started asking folks, I was told, well, we really don't need to feed them for a week. And I was shocked. So I wanted to figure out where this came from, and it turns out that in 2009, Cochrane Review found that there was insufficient evidence for or against nutritional support in children during the first week of critical illness, mainly because the appropriate studies had not been performed. So the conclusion was we don't need to feed them. So I found that this was frightening to the point where I'm now writing grants trying to actually look at this in children with trauma, and mainly because this recent study that showed that when they looked at critically ill pediatric patients, so over 1,000 patients, they found decreased 60-day mortality in the group that got adequate protein intake. So now we're kind of doing the reverse from the kidney patients, that protein intake is actually really important. So if you compared patients who got less than 20% versus over 60% of the prescribed goals, you had an odds ratio of 0.14 for 60-day mortality. And basically they found that it was enteral protein delivery and not overall calories like we had thought for a very long time. So ultimately, achieving delivery of over 60% protein goals associated with decreased mortality in mechanically ventilated children. So enteral protein delivery is a modifiable risk factor of mortality that's in dire need of a shift in current practice given the potential for improved outcomes. So therapeutic strategies, of course, it makes sense to actually consider supplementation. And just one point I wanted to make was that nutritional deficiencies rarely occur in isolation, although I've focused on arginine. Patients for sickle cell disease, for example, have multitude of nutritional deficiencies that we really aren't doing a good job of addressing. The ideal formulas for trauma, critical illness, pediatrics don't yet exist, and really more research is needed. And I'll end there because I'm out of time. I'll also end with the fact that my bias, that nutrition is medicine and we should be paying more attention to this. Thank you very much.